Now, various forms of hypofunctioning, it very much depends on what the nature of the disease is. Type 1 diabetes is a hypofunctioning because there's some sort of unknown injury on a genetic basis. Maybe there's an infection, maybe it's bad luck in a genetically predisposed injury and your pancreas gets killed off in some sort of unknown autoimmune thing. Well, on the other hand, your pituitary in pregnancy. Pituitary in pregnancy gets really large, and after pregnancy, the blood supply involutes. That is also known as Sheehan syndrome. Well, that's a bit of an infarction, a kind of a large-scale apoptosis. The example we gave before about the person who's got disseminated Neisseria meningitis and results in hypotension, tachycardia, is infection, Waterhouse-Friderichsen syndrome, infarcting off an infection in that adrenal gland because it's got an infection. Oh, next one, we have a person with acromegaly. They got a big macroadenoma in my pituitary. Big macroadenoma in my pituitary, and the macroadenoma is squeezing the thyrotrophs. Hey, give me some room here. Your acromegaly, prolactinoma, oh my God, I can't grow. And what happens is you get hypothyroidism. Why? Because the macroadenoma from the acromegaly is squeezing my thyrotrophs, the one that would make TSH. So it can be pregnancy causing vascular abnormalities and infarction. It can be autoimmune, like in diabetes, antibodies attacking your pancreas for some particular reason. I don't know, why do some people get depression and I don't? Well, why are some people attacked by things and make you sick? I don't know. Is it genetic? Is it a spiritual disorder? I don't know. It could be simple pressure, like any tumor in the pituitary that gets large and squeezes the other ones. Squeezing it. Infarction in Sheehan syndrome. Infection in Waterhouse-Friderichsen syndrome. Autoimmune, we think, in diabetes. Any of those mechanisms. It depends on what the organ is. Depends on what the organ is. Next. How do I see if you're pituitary? This one, hypothalamic hormones test pituitary reserve. What the hell does that mean? What does that mean? See, that's one of those statements that you'll see all over the place, that if you know what it means, it looks very clear. If you're learning for the first time, you go, what does that mean? You know what the difference between me is and the other people? I don't expect you to understand that statement. Well, how do we know if your pituitary is clicking? How do we know if it's working? How do we know if your pituitary will really make TSH? How do we know if it's really going to make ACTH? You could, theoretically, give the hypothalamic hormones, thyrotropin-releasing hormone, corticotropin-releasing hormone, growth hormone, releasing hormone, and see if it gives your pituitary a little tickle. Tickle, 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 tickle. Tickle, 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 tickle. That is my version of the pituitary hypothalamic system. I give you TRH, tickle, 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 supposed to make TSH. Growth hormone, releasing hormone, tickle, 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 release growth hormone. Thyrotropin releasing hormone, tickle, 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 TSH. You ready? Look, there's life and there's the boards. And in order to understand the physiology, those hypothalamic, see this again? Hypothalamic hormone tests, anterior pituitary reserve, you give the things that would normally come out of your hypothalamus, TRH, CRH, growth hormone releasing hormone, gonadotropin releasing hormone, and measure the blood level of the pituitary hormone before and after. Clinically speaking, these tests are rarely, if ever, done, but they help us to understand normal pituitary functioning. They help us to understand it. This last one, inducing hypoglycemia stimulates the release of all stress hormones. This is what do we call that? This is like an interrogation method. This is inducing hypoglycemia. Yeah, this is the basis. I give you an injection of insulin. I watch your blood sugar go down, and your growth hormone level is supposed to go. Your growth hormone level is supposed to go up. I induce the hypoglycemia, growth hormone should go up. I induce the hypoglycemia, cortisol level is going to go up. That thing about inducing hypoglycemia to stimulate the release of stress hormones, that is mostly useful for pan-hypopituitarism, to look at growth hormone release. We test cortisol through other methods, catecholamines just by measuring catecholamine methods. So again, as an isolated fact, it's true. It's not the same thing as saying, what is the most accurate test I would do for the patient clinically? But it is a correct mechanism. See the concept? You saw me smiling before? Because it's like this. Doctor, did you get the right diagnosis in my husband of his pituitary disorder? Yes, absolutely. Are you certain? Yes. What did you do? I gave him an injection of insulin and bottomed out his blood sugar, and he did in fact release growth hormone. Thank you, doctor, you're wonderful. Where do I see my husband? In the morgue. We killed him with the test. So the good news is you get a specific diagnosis. The bad news is inducing hypoglycemia is on the dangerous side. But physiology questions, that last question here, inducing hypoglycemia, releasing stress hormone, I'm going to be the question that goes with it. Ready? You have a patient that is coming in who's tired, also tired, but not French. Someone who comes in who's tired, more than just a French level of tiredness. Okay? I know my friends in Paris watching this now, right? Is that the American asshole making fun of us in France? I'm going to yell at him, except I need to take a nap now. So, I'm tired, I'm also tired. Well, is that tiredness because of panhypopituitarism? Well, why not measure the TSH level? Well, TSH could be low for other reasons. TSH might be just low because you're missing that one portion of it. ACTH level low, well, just the one portion of it. So there's ACTH levels, but the problem is that ACTH levels have a variation. Is it low because you're deficient, or is it low because it's just that time of the day? Is it low because you're deficient, or is it low because it's just that time of the day? Well, I give you hypoglycemia, and it's supposed to provoke a growth hormone surge. It answers this question. Tired patient, which of the following is the most accurate method of diagnosing panhypopituitarism? What is the most accurate method of diagnosing panhypopituitarism, inducing hypoglycemia, or injecting arginine? Next slide, hyperfunctioning. Now, what is the difference between this term here, you see this word hyperplasia, and dysplasia? Hyperplasia and dysplasia. Hyperplasia means increased growth. Hyperplasia means the cells are largely normal. They're just too many. An example of hyperplasia is benign prostatic hypertrophy, fibrocystic disease of the breast, hyperplastic polyps, hyperplasia. Is hyperplasia premalignant? No. Dysplasia is evil. Dysplasia is evil, not semi-evil, not quasi-evil, not the margin of evil. But dysplasia is premalignant. Cervical dysplasia wants to become cervical cancer. Dysplastic polyps want to become colon cancer. Dysplasia, myelodysplasia wants to become leukemia. But hyperplasia, no big deal. Just increased growth. Just increased growth. That's why in endocrinology, many of the tumors that make the hormone disorders are not what we'd call malignant. Adenomas, technically speaking, are not malignant. Pheochromocytomas, they make bad functions, but they're not malignant. They're like me. They're just hyper-functioning. They upset you every once in a while, but I'm not malignant. There's a difference between malignancy and just increasing the function. Pituitary adenomas are not malignant. Pheochromocytoma, not malignant. Adrenal adenomas making Conn syndrome, not malignant. Adrenal adenoma making cortisol, not malignant. Not malignant. So there's a difference. Myasthenia gravis. Myasthenia gravis, what do you get? Thymic hyperplasia. A lot. Thymic malignancy, un peu seulement, small, small. Now, the next piece of this slide, the concept suppression testing, answers the question, what is the most accurate diagnostic test? Now, let's take these examples. The two biggest are cortisolism, Cushing syndrome. Now, the term Cushing syndrome often gets used interchangeably with hypercortisolism, and that's okay. Cushing syndrome, technically speaking, means any form of hypercortisolism. Cushing's disease means an actual adenoma in the body. But Cushing's syndrome can be from taking prednisone too much because you're asthmatic. So hypercortisolism in general, well, we give you dexamethasone. If you suppress, it's normal. If you don't suppress, it's a disease. Now remember that disease does not have to be a malignancy. Malignancy implies a special evil cancer. So disease, yes, does not mean malignancy. It's very hard for people at the beginning. They go, adenoma, isn't it a malignancy? Not really. Well, what causes it? What caused the adenoma? Well, I don't know. I don't know. What caused the adenoma? Right, I don't know. But it's not necessarily a malignancy, okay? Another good example of this is Conn syndrome. You could have a solitary adenoma. What causes that? I don't know. And it's someone whose aldosterone level is up despite hypertension. It's not suppressing. Hypercortisolism, not suppressing with dexamethasone, disease. Growth hormone, not suppressing with glucose, it's a disease. The fundamental failure of biological tissue to fail to respond to feedback inhibition. The failure to respond to feedback inhibition is a fundamental definition of disease. Failing to respond to suppression test equals disease. It's like criminals in the society. Hey, don't do that, said the cop to the guy driving down the street doing something wrong. He doesn't do it and he stops. Okay. Hey, don't do that, said the cop to the guy driving incorrectly. And he continues to do it. Don't do that, said the cop to the guy. Don't do that. And he continues to do it anyway. He's not responding to suppression, normal suppression. You're at home in your relationship, and your wife says, stop telling those bad jokes, stop drinking out of the carton, stop leaving the toilet seat up. And you don't do what she asks. You don't suppress the bad behavior. That's a disease, leads to divorce. So failure of suppressive therapy leads to divorce. It's the same idea. Doing the weird thing is not so much the problem. Failing to suppress it when asked, that's the problem. So failure of suppression is a fundamental characteristic of diseased tissue. Having a high cortisol level is not a disease. Having a continued high ACTH level despite a high cortisol is a disease. Having a high thyroid hormone level is not a disease. Having a high TSH despite the high thyroid hormone level, that's a disease. Jumping up and down and being loud is not a disease. Continuing to do it when you're at church, mosque, temple, or shul, that's a disease. Failure of suppression. Gland structure and size. So what ends up happening is this is like any other business. For anybody who's ever run a business of any kind, this one is not too surprising, which is that when the gland doesn't work, when it's not being used, it should atrophy. Here it is. When the gland does not receive its normal stimulus, it should atrophy. Should atrophy. Well, that goes like this. How do you tell, you ready? How do you tell whether I'm hyperthyroid because I have a disease from my thyroid, or maybe I'm worried about my weight and I go out and I take Synthroid at night because I think I'm fat. I'm an anorexic and I think I'm fat. So I take Synthroid at night. What happens to my gland? Atrophies and involutes. Okay. Well, what happens to you if you take steroids because you're a chronic asthmatic, or steroids to prevent bone marrow transplant or organ rejection? What happens to your adrenals? They atrophy. Why? because it shuts off ACTH. All those bodybuilders, yeah, the professional athletes, yeah, they're taking these things, yeah, very big and strong and very macho, yeah. You can go up to them and say, ah, yes, your pectorals are very large. Your deltoids and biceps are very large. But I know something about you that's very small. So what happens is when you take an exogenous hormone, it atrophies the gland. You take Synthroid, your thyroid suppresses. You take steroids, your adrenals suppress. You take testosterone as part of your bodybuilding wrestler thing, and your testicles atrophy. But it's reversible. They'll come back right to life. They don't die. They just atrophy. They don't die. They just atrophy. The most important one is the hypothalamic pituitary adrenal axis, because the question goes like this. A person has been on high-dose steroids for 4 weeks for severe asthma. The steroids, the prednisone, is stopped suddenly. The patient the following day becomes hypotensive. Which of the following is the mechanism? Now, a step 2 question would say, what is the next best step in management to this patient? And the answer is you're supposed to say taper the steroids. A step 2 and 3 question go, what would you do to manage it? What's the action? What's the step? What's the action? What's the therapy? The step 1 question says, what's the mechanism? You stop the steroids and he develops hypotension. What's the mechanism? And the answer is suppression of the hypothalamic pituitary axis, suppression of ACTH, atrophy of the adrenal glands. It needs time for it to come back to life. Now, in this last part here about Graves' disease and overstimulation of thyroid tissue, the overstimulation of the thyroid tissue is because you become allergic to your own thyroid gland. You get thyroid-stimulating antibodies. Thyroid-stimulating antibodies. You get antibodies that actually simulate TSH. Wow. You get an antibody that simulates TSH? Yeah, it attacks the thyroid and goes zzz. But the only thing I'm going to tell you that's not always useful, you see the goiter story here? Goiter just means a big thyroid. Goiter by itself is not going to help you. Goiter can be hyperfunctioning, hypofunctioning, normal functioning. Goiter doesn't help you. However, overstimulation causes hypertrophy. Overstimulation causes the hypertrophy. You have a person who makes thyroid-stimulating hormone too much, it can make your thyroid gland large. You have a person that makes ACTH too much, it can make your adrenal glands large. Now, tumors can be both hyper-functioning and hypo-functioning. Cortisol tumors, well, you could have a person who's going to have a tumor that is compressing the normal tissue, low functioning. You could have a tumor that is overproducing ACTH, hyperfunctioning. So tumors can be either one. As a matter of fact, you ready? A patient is found on routine exam to have a thyroid nodule. Very common, 5% of the population at some point. At some point in the lifetime. Is found to have a thyroid nodule. What is the next best step in the management of this patient? What would you do first to evaluate the thyroid nodule, the thyroid tumor? And the answer is T4 and TSH, thyroid hormone levels. Why? Because cancers are non-functional. Cancers don't overproduce thyroid hormone. So tumors can be hyperfunctioning or low functioning. Okay, so the statement, tumors may also create hyperfunction, is the correct statement. But the key word is may. Tumors may increase function, may lower function. So that is the end of the general systems for endocrinology. But the most important thing with this general systems for endocrinology is to understand this. Steroid hormones don't have their effect on the surface. They must diffuse inside the cytosol. They must diffuse inside the cytosol into the nucleus. Then the nucleus must make new genetic machinery to make a new protein, and that is slow. Peptide hormones have an effect on the surface. The peptide hormone attaches to the receptor, not the G protein. The receptor says, hey, yo, G protein, go do something, huh? Go phosphorylate, cyclic AMP, calcify, inositol triphosphate. Yo, G protein, do something. And that's kind of what it's like. You know, you're in a restaurant. The waiter is a receptor. The G protein is the guy who's cooking in the kitchen. The person he actually comes and tells you, oh, well, you know, let's actually deliver the food at is different. So the waiter is not that performing the function. The waiter is the receptor. The head chef is a G protein. And the various other chefs are the second messengers that create its activity. Next, all peptide hormones are water-soluble, except IGF. All steroid hormones are lipid-soluble, except DHEA, which is sulfated. All hormones are made in pulsatile fashion, except thyroxine, which is constant. And that's the fundamental difference in those systems. Permissive action, really cool. Cortisol is permissive on catecholamines. Cortisol is permissive on glucagon. And thyroxine is permissive on growth hormone. I'll see you in the next section.